Small airways disease, there's a huge list of diseases that can cause or have small airways involvement. Infections, malignancies, congenital or acquired abnormalities. And the thing that these all have in common is that they affect the center of the pulmonary lobule. So obviously it's important to understand and know lung anatomy. And they affect the center of the pulmonary lobules in different ways. And the manner in which they affect that pulmonary lobule, whether there is filling of the airway, whether there is interstitial inflammation surrounding the airway, dense consolidation surrounding the airway, or airway obstruction, will determine what the radiology looks like. And so my goals today are to talk about the different CT patterns you may see and how they relate to the particular diseases that cause them, and also to really give you a sense of understand why we're seeing what we're seeing. And I think the key to that is really understanding the pathology. So if you have a good pathologist at your institution, I urge you to get to know them very well. My pathologist is great, so I'm very lucky. And I get a lot of good pathology images from him, and it really gives me a lot of insight into why I'm seeing what I'm seeing. This is the classic radiographic classification of small airways diseases. Ill-defined central lobular nodules, nodules with tree and bud, focal bronchiolitis with focal lung lucency, and bronchiolitis with ground glass or consolidation. We use a slightly modified version of this at UCSF. The fourth pattern is generally, the archetype of that pattern is organizing pneumonia. And organized pneumonia, as you probably all know, is more of an alveolar disease than an airways disease. The airway component is relatively minor, if it's there at all, in both a radiographic and a physiologic sense. So generally, we just don't consider that really a small airways disease. And we're going to add one pattern here, which actually has a lot in common with tree and bud, which is soft tissue or dense central lobular nodules. And we'll talk about how there's some subtle differences between those two, but it does have a lot in common with the nodules with tree and bud. Always remember that at the center of the lobule is both the bronchiole and the artery. And so processes that affect the center of the lobule may be both airways related or vascular related. Now the airways diseases are by far the most common, so when you see one of these patterns, that's going to be right at the top of your thought process of the diseases, what's causing this. But there are certainly vascular causes of all these patterns, which I'm not going to get into a lot of detail about today. But, and when I think of these, patients with pulmonary hypertension would make me think of these diseases. Patients who have maybe very diffuse abnormality, like 3 days of symptoms, you think of hemorrhage or edema or something like that. So keep this in mind, that this is always in the differential diagnosis. So let's go through the different patterns. This is a very nice example. This is probably the #1 most shown case of UCSF chest radiology. We pass this around like it's an Olympic torch from person to person and go from meeting to meeting showing it because it's such a beautiful example of what it is. And you can see that this is a beautiful example of central lobular disease. Why? Because there's striking sparing of the subpleural surfaces, including the fissures and the peripheral subpleural interstitium. The nodules are spaced about a ½ millimeter or so away from those surfaces. So a beautiful example of central lobular disease. And the nodules are predominantly of ground glass opacity or ground glass or ill-defined. They tend to be fairly small, as opposed to the nodules of fungal infection, which are very large. So often small, and the areas that are affected, they're relatively homogeneous in size. And the distribution may be diffuse, like it was in that case of hypersensitivity, or may be patchy. The pathologic correlate of this finding is inflammation, or much less likely, fibrosis surrounding the airway. Peribronchial inflammation usually. And more commonly, it's interstitial than alveolar. For instance, hypersensitivity pneumonitis, and I'll talk about why that is in a second. Occasionally, alveolar disease will do this, but more commonly, it's an interstitial process surrounding the small airway. And then what's absent is airway thickening, airway impaction, filling of the airways, and then dense confluent consolidation surrounding the central lobular lobule region. Some things you may want to think about in terms of putting this in a perspective is exposures like birds or dusts or mold, smoking history, and then underlying systemic disorders. Okay, so we're talking about nodules involving the central portion of the lobule, which look ill-defined, and again, you can see the nice distribution, how it's going to be about 5 millimeters from the subpleural surfaces. The pathology, you can see there's the airway running at the center of the lobule, and we can see this interstitial inflammation in this patient with hypersensitivity pneumonitis, and notice how it kind of peters out here at the subpleural surfaces. So this is the pathologic correlate of this radiographic appearance. And as I said, more commonly, not always, but more commonly, this represents interstitial inflammation. And when you have inflammation within the alveolar septal walls, there's the bronchus. Actually, even we'll see a little bit of lambertosis, which is bronchialization of the alveolar walls adjacent to the bronchi. But there's airway thickening with air and alveoli, and when those average between the two, you get ground glass, as opposed to a patient with dense consolidation where it looks more solid. And there's the correlate on CT scan, another nice example of HP, which is by far the most common disease to give this pattern. You can see the nodules lined up like little soldiers along this, about 5 millimeters from the subpleural interstitium. Differential diagnosis, HP is the vast majority of cases, and if you have this CT scan and a clinical and exposure, it's considered diagnostic, and we will not get a biopsy in those cases. Of course, that only happens in about 50% where you have the exposure. Respiratory bronchiolitis in a smoker, HP is somewhat less likely in a smoker, so we think of respiratory bronchiolitis. If the patient has connective tissue disease or some sort of immune suppression, like common variable immune deficiency, you may think about follicular bronchiolitis. If they have an acute infection, we think mainly about viral infections where you have peribronchiolar, interstitial, and maybe some alveolar inflammation. Usually this is very early in the process of a viral infection before more generalized diffuse alveolar damage has developed. And then occasionally pneumoconioses. Usually silicosis and coal workers produce more well-defined nodules. Occasionally they can produce this pattern, but probably the more common one we see is in welders who have siderosis, where it's just deposition of iron adjacent to that bronchiole without a lot of lymphatic drainage or reaction to it. Here's a case of respiratory bronchiolitis. On the pathology, you see the nice example of relatively subtle interstitial inflammation and cellular inflammation in the interstitium surrounding the bronchiole. We see some pigmented macrophages here. The inflammation tends to be somewhat less than HP, so the nodules that we see are often very, very indistinct, almost things you would pass over if you weren't looking too carefully. Here's a case of siderosis. The arrow is pointing to a nice example of a central lobular ill-defined nodule. And again, what we're seeing here is mainly just deposition of iron around the airways without a lot of lymphatic drainage or reaction to it. Okay, so that's ill-defined central lobular nodules. Tree and bud looks very, very different. And here's a nice example there in the left lower lobe in particular. We see these branching tubular opacities. Their density they're much denser than the ill-defined nodules we just saw. And along the branches, we have a few nodules. And of course, that corresponds to this, which we've seen earlier. This is one of my trees in the spring right about now when the buds start to swell. The importance of tree and bud, well, it's a subtype of central lobular nodules, so these also should be spaced away from the subpleural interstitium, and they are branching with nodules, and it's often associated, now what we're seeing with tree and bud is essentially filling of the bronchi with usually infectious debris. That infectious debris may not stay there, it may extend outwards. So these are often associated with consolidation centered upon the center of the lobule, depending upon the stage of development. And it represents pathologically filling of the airways with various materials, and then that material over time can spread into the adjacent alveoli. And you could develop consolidation centered within the center of the lobule. And of course, immune status is very important in distinguishing the different infections, or at least the likelihood of different infections. Chronicity of symptoms, more chronic cases, you maybe think of MAC, or maybe think of something else like an invasive mucinous adenocarcinoma. And then this is some of the systemic disorders like HIV, like immunodeficiencies and connective tissue disease. Okay, so in this case, we're talking about filling of the airways with usually infectious debris, and that's what gives us this appearance. And over time, that will spread out into the adjacent alveoli. The importance of tree and bud is it's virtually always infection or aspiration. Those are, the specificity for infection or aspiration is very high. And you can include some what I call sort of infectious variants, which are basically infection in the airways and mucostasis. Like ciliary dyskinesia, where you're not clearing secretions normally and you get chronic infection in the airway. In most cases, the infectious variants are going to have some other findings to lead you to that diagnosis because they tend to be severe airways inflammation and chronic. So you often have just more large airways involvement, bronchiectasis, inflammation. There are non-infectious causes which are quite rare. So we usually don't think of these unless there's an important clinical history, with the exception of aspiration, which we've found is a not uncommon cause of tree and bud. But things like allergic bronchopulmonary aspergillosis, so in an asthmatic, you may want to think about that disease. Or things like the one big non-infectious cause of tree and bud that we have seen is follicular bronchiolitis, and what leads us to the diagnosis is going to be the history of connective tissue disease or immune suppression, and often it's very, very symmetric, and the nodules are all very small, which would be a little bit unusual for garden variety bacterial pneumonia to do, which would be more patchy and more heterogeneous in size. We have actually never seen a good case of tree and bud in invasive mucinous adenocarcinoma or multifocal BAC, although it's been described, but we've actually never seen a very good example of tree and bud. And occasionally processes that surround the bronchiole, like sarcoid, can give you what I call pseudo tree and bud, but there's usually going to be other nodules in other locations, subpleural nodules, more typical hilar predominant symmetric lymphadenopathy. So usually it's infection. So here's an example of a rare atypical mycobacterial infection which really shows the progression of disease over time very nicely. We have tree and bud, again, that's mostly filling of the small airways with infectious material, and then that extends into the central lobular, the alveoli surrounding the center of the lobule, so we have more of these dense nodules, some of which are relatively small, some of which are bigger, and then more confluent areas of consolidation where the process has just been going on for a while longer. Here is what those nodules represent. You have impaction and you have consolidation. You have confluent alveolar disease centered upon the bronchiole, the central lobular bronchiole. And that's why these nodules tend to look much denser than what's more commonly the interstitial inflammation of the first pattern, typical of things like HP. So consolidation begins here, but it doesn't end there if it's not treated appropriately or the immune system doesn't handle it, and it eventually fills up that entire pulmonary lobule and produces areas of more confluent consolidation. Here's an example of cystic fibrosis with nice examples of tree and bud, and it was some pretty, bilateral and upper lobe predominant, a little bit asymmetric, and this patient also had more central areas of bronchiectasis. So just an example of someone who has both large airways and small airways involvement with this process. An example of a MIP on someone with primary ciliary disorder. Lots of good examples of tree and bud, and they follow right back to the more central airways. And again, this is chronic mucostasis, chronic infection, mainly contained within the lumen of the airways and a little bit of inflammation surrounding the airways. Someone with ABPA and central lobular nodules, tree and bud, there on the right. A little bit in a slightly different location, had more typical cystic bronchiectasis and mucus impaction. Patient has asthmatic. That combination is pretty typical of allergic bronchopulmonary aspergillosis. We try to maintain our specificity for calling tree and bud because we want to be highly specific for infection. This was called tree and bud, but I don't see a good example here. And I think when the nodules are patchy like this, we just assume, oh, it's infection. There's a tree and bud. That's pretty good enough. But the other distribution of nodules that may be patchy like this are lymphatic processes. So the goal is we don't call tree and bud unless we see a very good example of it. This patient actually had a follow-up which was totally stable, so we recommended a high-res CT, and there are clearly subpleural nodules which you should not see in patients who have tree and bud. So this was a patient with sarcoidosis who also had some peribronchovascular nodular thickening. Okay, so just don't make that mistake. Be specific. Now, not all patients with pneumonia will have tree and bud. Some patients will look like this and just have these nodules, which appear denser than the first pattern of the ill-defined central lobular nodules. And so we sort of include this as a separate category, but very closely related to the tree and bud category. And you can see a nice example of nodules of different sizes, smaller nodules, somewhat bigger nodules as they start to fill up that entire lobule, and then very large nodules almost filling up a pulmonary lobule. So this is different stages of evolution in someone who had a basic old bacterial bronchopneumonia and did not have tree and bud here or anywhere else. And our differential is just a little bit broader. Usually infection, aspiration, that's it for tree and bud. Some other things we've seen in the more chronic setting, you can think of multifocal BAC or invasive mucinous adenocarcinoma, and then Langerhans. Often you'll see the cavitation and cystic changes with Langerhans, but occasionally you'll just see the nodules. And they can be ill-defined, but they tend to be more commonly this density, more dense, because they're more discrete collections of Langerhans cells. Here's a nice example of invasive mucinous adenocarcinoma, showing a very similar pattern. Invasive mucinous adenocarcinoma certainly may present with ground glass nodules, but in our experience, it much more commonly presents with these dense nodules. And if a patient has both ground glass and dense nodules, usually we sort of use the dense nodules in our differential diagnosis. So there's, again, you see smaller nodules. Notice it's distant from the fissures. You have bigger nodules, and then these very large confluent areas of consolidation. Okay, third and final pattern is bronchiolitis with focal lung lucency. You see an example like this. You have heterogeneous lung density, lucent and opaque lung. In this case, I'll tell you the lucent lung is abnormal, but that may not be clear. So the one question would be, how do we differentiate when the lucent lung is abnormal and the pattern is mosaic perfusion, and how do we differentiate when the opaque lung is abnormal and the pattern is ground glass opacity? So in mosaic perfusion, due to bronchiolitis, the obstruction or stenosis of the airways leads to decreased ventilation. Decreased ventilation leads to reflex vasoconstriction, and thus why we call it mosaic perfusion. And the decreased perfusion causes decreased areas of lung attenuation. That's the pathophysiology behind why the lung is lucent. When we are differentiating mosaic perfusion versus ground glass, most commonly is this very sharp demarcation. Ground glass most commonly is an acute alveolar process, not always, but often is. And often at the edges it appears very hazy. It kind of blends into the more normal lung. Whereas mosaic perfusion is obstruction of very focal airways, and the airways would just be knocked out of the lung. So you see sort of I always tell my residents, it's like you took a cookie cutter in the shape of a few lobes and just sort of knocked it out of the lung. So that's one. Number two is helpful if you see it. It's not helpful if it's absence, but difference in vessel size. So in mosaic perfusion, the lucent lung, the vessels may be much smaller in the lucent lung than in the normal opaque lung, and that may be helpful in telling that the pattern is mosaic perfusion. If you see air trapping in the areas that were lucent on the inspiration, then that just confirms that the pattern was mosaic perfusion. And I find stability over time can be helpful. Again, because ground glass is often an active alveolar or inflammatory process, and it usually changes over time. So if you feel very, very stable findings over a period of time with two densities, at least consider that the lucent lung is the abnormal one. I'll show you a good example of that. Okay, so just to drive home the point of differentiating lucent from opaque being abnormal, these are all cases of mosaic perfusion. This is a case of neuroendocrine hyperplasia. Notice the very, very sharp demarcation between lucent and opaque. The lucent lung is abnormal from small airways disease. This is a patient, I believe, just with asthma who has an abnormally lucent lung, and on the expiratory that stays quite lucent, whereas the more opaque normal lung, as it should, gets denser on the expiratory image. And this is actually a patient with chronic PE. Sorry, that's in there for a airways talk, but you can notice, and that's particularly prevalent with vascular causes, the vessel size difference. Notice the tiny little vessels in the lucent lung and the more opaque, or larger vessels in the more opaque lung. Okay, so this is an example of neuroendocrine hyperplasia, and the archetype of this pattern, the disease that probably commonly produces this pattern, most commonly is constrictor bronchiolitis or obliterative bronchiolitis or bronchiolitis obliterans, whatever you want to call it. They're all sort of synonymous. And in this case, you have fibrosis of the airways, but you can't see that fibrosis that surrounds the airway. We can't resolve that on a CT scan. So what we see is the downstream sequela of that airway obstruction, which is decreased ventilation, decreased perfusion, and decreased lung attenuation. Here's a path example of constrictor bronchiolitis. This is in, I believe, in that category where if a pathologist sees a normal exam in someone with symptoms, this is one of the diseases that can produce that. These findings can be extremely subtle on path, and thus we often don't see them in a CT scan. But that's where the smooth muscle should be, and this is an airway at the center. And in this case, this is mostly fibrosis surrounding that airway. And this can be very, very subtle on path, and we can't resolve that airway fibrosis on CT scan. Another example of bronchiolitis obliterans in a patient who was in a fire. You can see a nice example of lobular mosaic perfusion on the inspiration. On the expiration, it stays quite lucent, and that's compatible with small airways disease. Here's where the stability over time, I think, can be helpful. When you see opaque and lucent lung, okay, well, it is sharply defined, but viral infections can sometimes be sharply demarcated like that. Because there's such a difference in opaque and lucent, we tend to think the opaque is abnormal. But this patient was exactly the same 6 months later, which would be unusual for viral infection or any other cause of ground glass to do that. On the expiration, you can see how the normal lung, which is this small sliver of lung, gets denser, and everything else stays about the same. Pulmonary function tests may be very helpful here. This patient had a horrible obstructive defect on pulmonary tests because essentially they had very, very extensive air trapping. Mosaic perfusion, a fairly nonspecific finding. It can be seen with any airways disease, such as in this patient with cystic fibrosis. And we essentially ignore it unless it is the predominant finding, in which case it's only a small group of diseases. Mainly one is constrictor bronchiolitis, asthma and HP are the other two where we can see this finding in isolation, and of course vascular diseases as well. So we've gone over these 3+1 patterns of small airways disease, why they look the way they look, and the differential diagnosis.